Okay. Hi, everybody, and welcome to our final presentation of our 2020 Health Psychology Seminar Series. We've had a whole range of great presenters, and we're so glad that you could join us. My name is Zoe Mushkat, and I'm the Health Psychology intern at the Jesse Brown VA. For those of us attending our live presentation today, please just take a second to make sure that your microphone is muted. And if you don't mind, type the name and location of your program into the chat box so that we can get a sense of who's joining today. You can also type any questions that you have into the chat box, and then we'll relay them to the speaker at the end of the presentation. I'm honored to introduce Dr. Angela Lawson, Associate Professor of Clinical Obstetrics and Gynecology and Psychiatry at Northwestern University's Feinberg School of Medicine. Dr. Lawson completed her PhD at the University of Illinois Urbana, and she's a licensed clinical psychologist specializing in women's reproductive health and sexual trauma. At Northwestern, Dr. Lawson provides consultation as well as psychotherapy related to infertility and other reproductive concerns. She also conducts research on the psychological aspects of infertility and gynecologic cancers. Today, we're so thrilled to welcome Dr. Lawson to present on the role of health psychology in reproductive medicine.
Thank you. I'm really excited to be here with you guys today. It's a topic that I'm pretty passionate about, obviously, given what I do for a living, but I think understanding more about the emotional aspects of fertility is something that's really important for all of us, because we might see fertility patients or patients with fertility concerns in our current or future practices, and yet we get very limited training about this topic. So my hope today is to talk to you a little bit about what infertility is and what medical fertility treatment looks like, but more so to focus on the psychological consequences of infertility and reproductive loss. I am going to talk a little bit about psychological causes of infertility, because there's a lot of people who believe that psychological stress or distress actually can make it harder for someone to get pregnant or can cause a miscarriage. And so we're actually going to talk a little bit about that. And I'm happy, I don't really know how all this works, but I'm happy to answer questions in the middle of the talk, at the end of the talk. Anyway, is fine with me. But I wanted to start a little bit by talking about infertility. So infertility is actually a lot more common than what people realize. Depending on the research that you're looking at, between 1 in 6 and 1 in 8 couples in the U.S. struggle to conceive a pregnancy or carry to term. And there are millions and millions of babies in the U.S. and worldwide that have been conceived with fertility treatment, over 8 million worldwide from IVF alone. And it's not just what you might think of in terms of a traditional infertile couple that's been trying to get pregnant and is not able to get pregnant who comes into a fertility clinic. Certainly those couples come for treatment, but also people with cancer who are going to be exposed to gonatotoxic chemotherapies, radiations, or surgeries might come in to preserve eggs, sperm, or embryos before they undergo cancer care. Single men who are getting older may worry about their ability to father a child and might either bank sperm or might come in to be single fathers. Single women, again, coming in to be single moms or to freeze their eggs. Transgender patients who are struggling to conceive, and the list goes on and on and on in terms of who we see in fertility clinics. Just a special note, though, about those cancer patients. Whenever I talk about cancer patients coming into the fertility clinic, sometimes it makes people a little bit nervous because they think about, well, these patients have cancer. They need to get the cancer resolved before they do anything about fertility. And in actuality, not only is it safe to undergo fertility preservation prior to cancer treatment, it only takes us about 2 weeks on average to make embryos. So we're very quick at doing this, and we just had a manuscript accepted this past week, which shows there's no increased risk in morbidity or mortality for cancer patients who come in and undergo fertility preservation before they start their cancer treatment. And that's really important because patients who are going to lose a lot because of cancer treatment don't also want to lose their ability to be parents if they want to be parents. But we'll talk a little bit more about that. But when we think about folks who then come into fertility treatment, it's also not only diverse who comes into treatment, but it takes a bit longer than what most people think. It's not usually a one and done. So couples who are coming in for fertility treatment because they're struggling with infertility usually have been trying for at least a year on their own before their insurance will kick in and cover their fertility treatment. And in the state of Illinois, Illinois is one of, I think now 17 states that has a fertility mandate, which means if you have an Illinois-based employer, and they get their insurance from the state of Illinois, which is also important, they are required to cover you for at least part of your fertility treatment. In other states, individuals have to do GoFundMes, take out loans, because fertility treatment is really expensive. And because it's not this one-time process, then there's multiple cycles of IVF or IUI or different types of fertility treatment that you're going to be paying for. The average amount of time that someone is in a fertility clinic is about 8 months. And that means a number of additional cycles and ultrasounds and expenses that you're going to be incurring in fertility care. So the way that this typically occurs, how do you get from walking through a clinic's door to 8 months or to getting pregnant? Folks who walk through the clinic's door because they're infertile are typically started on something called ovulation induction, where we have you take some medications that can encourage ovulation, typically letrozole or Clomid, clomiphene citrate, and then you have timed intercourse at home. Most couples who come into the fertility clinic are not having sex wrong. Some people are, right? Nobody teaches us how to have sex. They only tell us not to have sex. And so most couples have been getting timed intercourse correctly, and so they actually can skip that stage, right? Or, if a woman has PCOS and she's not ovulating regularly, that might be the couple that we give medication to and say, try it home for a couple of months. If it doesn't work, come back in and we'll move on to IUI. So the most people start at OI, and then fewer people, it's this funnel effect, fewer people then move on to IUI. IUI instead of OI, intrauterine insemination, means that we not only give you these hormones to take, but we get the sperm sample, put it in a long skinny catheter, and insert it into the uterus at the time of ovulation to try and encourage pregnancy. Some women, though honestly, not very many, will get pregnant through IUI. IUI is simply the medicalization of sex, and we have all been lied to about what our chances are of getting pregnant through sex. So typically the max chance you have each month with an IUI of getting pregnant is about 15%, which means there's an 85% chance you do not get pregnant each IUI. But some people do get pregnant with IUI. Those that don't move down that funnel and move to IVF. Now, IVF, because it is more invasive and we're putting the sperm and eggs together, drastically increases one's chance of success. It also drastically increases the cost of fertility treatment. But with IVF, your chance of success basically triples over what your chances are with IUI. And many, many people get pregnant with IVF, but not everyone. Some couples are not able to get pregnant either because of a problem with their eggs, sperm, uterus, etc. And those couples then have to think about, do I want to choose to be child-free versus do I feel like I'm childless? And if I feel like I'm childless, then I'm probably going to think about alternate means of family building. You can use donor eggs, you can use donor sperm, you can move to donor embryos, although very few people move to donor embryos for a variety of reasons. One being there's very few embryos that are donated. Because of 23andMe and Ancestry.com, most people get a little nervous donating their extra embryos because that means those kids show up on your doorstep 20 years from now. Gestational surrogacy is not very common, even though you may see it in social media. To go through gestational surrogacy with a gestational carrier that you get through an agency costs between $100,000 and $150,000 per baby. So that's out of a lot of people's budgets. And we're getting a little glare here, sorry, from the window. And then adoption is also not super common. And I think there's a lot of misconceptions with adoption that people say, well, if you can't get pregnant, then you should just adopt. And first of all, I hate the phrase, you should just, right? Whatever follows it is going to be bad. But with adoption, I think people don't understand how difficult adoption is. It costs on average about $40,000, which a lot of people don't have. It's actually cheaper to do fertility treatment than to adopt. And it's about a 3-year wait. And the reason why is in 1970, that was the highest year of adoptions in the US. But after that, those rates of adoption went down because fertility treatments started to increase. And at the same time, social mores started to change, where there was greater support for unintentionally single moms, that they were no longer sent away to live with grandma and have the baby and place the baby for adoption, but families kept those unwed mothers at home. Those single mothers were able to raise their children on their own. And so there were also then fewer babies being placed for adoption, but there's just as many parents who still want to adopt. And so it created its own funnel effect. And for a lot of women and men, they want the experience of being pregnant, of one of them being genetically related to the child in case something medically goes awry. There's a variety of reasons why people don't choose adoption. Regardless of the path, though, that somebody goes on as they're moving through IVF, it's typically a long journey. And for those individuals who struggle to conceive, before they even get to treatment, they're already likely to be experiencing symptoms of depression and anxiety because something they've always wanted, or at least want right now, isn't working the way that they want, and they can't seem to make it work. That distress worsens across fertility treatment after multiple failed treatment cycles. And at the end of treatment, it can be so severe as to equal that of the distress seen in newly diagnosed cancer patients. Not only that, that distress can continue throughout the course of a healthy pregnancy and even after the birth of a healthy child. And you may be saying to yourself, okay, well, why is all of this distress starting, right? It starts because of all of the lies that we have been told about how our bodies and about how reproduction works. We are told from the time we are teenagers that it is so easy to get pregnant, that you have to work really, really hard to not get pregnant. It's easy. And so now all of a sudden, it's not easy for someone. And what people then say is, well, I mean, it's easy. I've heard all these stories of it being easy. And of course, nobody tells the hard stories and nobody tells the boring stories and nobody tells the stories of being drunk in the back of a pickup truck and not getting pregnant. We keep those stories to ourselves. And so all we hear are the easy stories. And so when somebody struggles, people are left scratching their heads and they're like, I don't get why it's not easy for you. Oh, I know why it's not easy for you. I bet it's your fault. And that's what people say. I bet you're doing something wrong. And if you just fix it, it'll be easy again because I want to believe that it's easy to get pregnant. And so that's what happens. Largely women, but men as well, say to themselves, oh my gosh, it's not easy. It's supposed to be easy. I must be doing something wrong. What did I do wrong? Well, then everybody starts to feel a little bit of a sense of loss of control, and they're trying to control everything they can to try and fix whatever the problem is. And the only thing we really have that much control over are lifestyle habits, diet, exercise, relaxation efforts, those sorts of things. So that's why people start talking about changing those aspects of their lives. That feels anxiety-provoking just saying it, right? People are making all of these changes and they're still not getting pregnant and they're not sure why. And now all of a sudden their image of themselves and their roles and their identities in society starts to change. What if I can't be a mom or a dad? What does that mean about me as a partner, as a community member? I'm never going to be able to give my parents grandchildren. And the anxiety just increases and increases. And then people are left wondering, well, if I can't have a baby, then what am I going to do? And the grieving begins. And it cycles back around and again and again and again. And so one of the things from the very beginning when I started working in the fertility clinic in 2008 that I heard from patients is this belief that not only is it our fault and largely women's fault, it's women who've largely been blamed for this. Of course, it was us that was blamed. Is that people would talk about, you know, I can change my diet, I can change my exercise, I can change all these different things. There's this one thing, though, that's really hard to change, and that's my stress levels. And historically, that's what people have heard. They've heard you're too stressed. You should just relax, which everyone hates that phrase, because even though you're trying to be helpful and saying, you know, just relax, don't think about it, you'll get pregnant. what you're really saying is it's your fault. You're too stressed. Maybe you should just quit your job, right? And then you'll get pregnant. And I wanted to know whether or not that was true. Because if it was true, then obviously we need to give everybody therapy, right? And find all sorts of ways for people to relax. But if it's not true, it's really, really hurtful. And guess what? It's not true. So it is an old wives' tale that stress affects our ability to get pregnant or that stress causes miscarriage. And the old wives' tale certainly began before we understood the way that stress hormones and reproductive hormones work in the body. So it just got more nuanced once we figured out how the HPG and the HPG axis work. But the basic theory from this sort of, busy graph is that when we're stressed out, there's this reaction in our brains, and it releases stress hormones, cortisol and alpha amylase, the two big hormones that we talk about with reproduction. And when these two hormones get released, they have a negative effect on the reproductive axis. Basically, it's fight or flight versus feed and breed, right? The parasympathetic and sympathetic nervous systems are fighting against each other, and that when we're too stressed, our bodies focus on survival, not on reproduction. And it's not true. So the body is constantly trying to maintain homeostasis. It actually doesn't shut down one part of our body just to have another part of our body work. And in fact, if it did, the species would have died, and every species would have died, because every species has undergone multiple periods of stress throughout, time, right? But it sounds fancy, sounds like it should be true. And so people have kind of gone with it, right? So I figured out what the biological plausibility argument was about stress, and I really dug into the research more. And what I found was surprising and disturbing. What I found is there's literally no relationship between stress or distress and fertility, unless you're so stressed that you're not having sex, but then your biology is not the cause, right? Or unless you develop functional hypothalamic amenorrhea due to stress. So functional hypothalamic amenorrhea is where a woman loses her menstrual cycle. But typically that is caused by dietary concerns or other physical concerns, not necessarily psychological distress. What we see in the research instead is that we have 47 randomized controlled trials and a Cochrane review on psychotherapy and pregnancy chances, and there's no relationship between them. We have 17 randomized controls on acupuncture in pregnancy, because people talk about acupuncture all the time, and it's lovely if you don't hate needles. It's awful if you do. Acupuncture doesn't change pregnancy outcomes. We've got lots and lots of studies on folks who either stop fertility treatment early or are waiting to get started in fertility treatment, or who adopt and get pregnant. And guess what? The folks who get pregnant are the folks who were going to get pregnant through sex anyways. They're the young folks, sometimes who get divorced and get new sperm, right? They get a new partner. But they're the ones who, if they kept having sex, still had a chance of getting pregnant, a reasonable chance of getting pregnant on their own. It has nothing to do with stopping or starting treatment. It's if you continue to have appropriately timed, unprotected intercourse, you have some degree chance of getting pregnant. And then we have literally hundreds of correlational studies, which don't get me started on correlational studies. They can be useful for all sorts of reasons, but if you start cherry picking a study that shows that stress causes infertility, I'll cherry pick 100 more that show that it doesn't. The best studies that we can look at are not even meta-analyses, because meta-analyses, that's just really cherry picking in action. We need randomized control trials. But what we can see from all of this research is that, I'm being generous here, and what I'm saying is that if, at best, stress might have an effect on fertility, maybe it changes the number of months to who's going to conceive, but everybody who's going to get pregnant anyway gets pregnant. And we've got a number of studies which show this. So you might be saying to yourself, Angela, I don't believe you. I know that you're saying that all this research exists, but my mother's cousin's brother's sister's wife, whatever, was super stressed out. And then she got drunk, went on vacation, adopted a baby, whatever. She relaxed somehow and she got pregnant. Tell me how she got pregnant, right? And Paul Meehl would have a thing or two to say about using anecdotal data. But what I would say is that the reason why somebody gets pregnant who has engaged in any relaxing activity is that number one, they had sex at the right time of the month, and number two, they didn't have a 0% chance in the first place. Again, if you continue to have appropriately timed unprotected intercourse, some folks are going to get pregnant. What I think is a more interesting question to ask is not about, well, how do I explain this anecdotal data? I think the more interesting question to ask is, how come nobody's sharing the other stories? How come nobody's sharing the stories of relaxing and not getting pregnant, doing acupuncture and not getting pregnant? I think the answer is because we don't want to hear those stories, right? But we're only sharing stories that we want to hear because we want them to be true. And that's what I think all of this comes down to. I think that from a scientific perspective, as healthcare providers and human beings, we want to believe that stress causes infertility because we need an answer. We don't like this idea of unexplained infertility. We need an answer as to why it's happening. But just because there's not a medically identified answer does not mean that stress or distress is the cause. It may mean that medicine and science has not advanced enough to help us figure out the answers, but it doesn't mean that, right? I also think, though, it's because all of us, whether we're healthcare providers or not, we want to believe. We want to believe that it's easy to get pregnant. We want to believe that we have control over our own fertility and that we can get pregnant whenever we want. Who cares how old we are? I feel young. I'm healthy. I've done the right thing. I've made the right decisions in my life. Because if what we've believed is wrong, if the number one thing that largely determines who gets pregnant and who has a baby is something we cannot control, our biology, then what that means is that fertility can be unfair. It means that really good people who'd be really amazing parents can struggle. And it also means that there's plenty of people out there who probably should never have children, who can blink their eyes and have as many kids as they want. And we just don't want that to be true. So instead we kick ourselves when we're down and we say that it's our fault. But it's not true. It is our biology. We have been lied to. There is an expected chance of success in getting pregnant through sex each month that we have quite a lot of research on. And what we know is that starting in our early 20s, I'm not going to talk about teenagers because their chance of success is higher, which is why our parents try and scare us. But starting in our young 20s, our chance of getting pregnant, our perfect chances of getting pregnant each month through sex is about 25%. By the time we hit 35, our chances are closer to 15. And what you see in this slope is starting at 35, there is this gentle initially but steeper decline right around 35. And that's why people talk about 35 being advanced maternal age. Our fertility doesn't literally fall off a cliff. People can get pregnant after 35, but it starts to get harder. And I think the real reason why we talk about 35 is because 38 is coming. And you can see it in this chart as well. We hit that 39 to 40 range, and you start to see that the blue line, right, your chance of getting pregnant, crosses with your miscarriage line, right? So as we get older, not only does it get harder to get pregnant, but it gets harder to stay pregnant. At 38, every 2 years after 38, a woman's fertility drops by 50%. That's why we talk about 35. Because if a woman hasn't had a baby by 35 and she wants to have more than one baby, then if she starts at 35, she might only be 37 or just shy of 38 trying for baby number 2. But if we wait to start after that, we might not get a baby number 2. That's why people talk about 35, not because we fall off a fertility cliff. So we know what the research says about what our real chances of success are and what our real chances of miscarriage are, and they are real. We also know what all the old wives' tales are related to fertility. And I'm guessing that you can guess what patients believe. Patients believe what they've been told, and what most of us have been told are the old wives' tales and not the research. So when we look at studies of patients' beliefs, unfortunately, what we see is that even among highly educated groups of both men and women, most patients believe that stress can cause a bad pregnancy outcome. Many patients, a quarter of them in this particular study, believe that women should just avoid upsetting things altogether because that can cause bad outcomes, like funerals. Shouldn't go to them because you can have a miscarriage, right? There's a lot of people that think exercise can cause a miscarriage, or that the women are some way at fault for having a miscarriage. What I say about miscarriage is that women don't miscarry, embryos miscarry. There was something wrong with the embryo, and certainly well over the majority of the time, it is a chromosomal anomaly that leads to a miscarriage. It is not a woman's fault. If it was that easy for women to screw this up and have miscarriages, the species would have died off generations ago, right? If stress had the ability to affect the survival of our species, we would have died off generations ago. Think about women living in third world, famine-ravaged, war-torn countries, afraid for their lives every day, working in fields with zero medical care, and they get pregnant and they have babies. And yet we continue to believe that it's women's fault because they're too stressed. This is another study which looked at people's beliefs about miscarriages, and we are clearly doing a horrible job of educating people about what realistic chances of miscarriages are. At age 35, your chance of having a miscarriage is between 1 in 5 and 1 in 4. And yet in this study, people believed that your chance of miscarriage was less than 5%. It's not even close to 5%. Starting at age 25, our chance of miscarriage is already 15%. So it's much higher than what people realize. But we are, again, not helping people understand this. And miscarriage, I think, is pretty important to appropriately educate people about in terms of what the cause might be, because if you've had a loss, a pregnancy loss, not only are you grieving that loss, but now if you feel like you're the one who caused yourself to have a loss, your grieving is going to be far harder and last for far longer than if you were able to understand. And many people in this Bardo study did, that genetic anomalies or chromosomal anomalies cause those miscarriages. But if 76% of women who believe that having a loss is their fault, that has got to be awful for those women. And it's why I think there's such a stigma around talking about miscarriages. Women are afraid to say that they've had a miscarriage because even today, the first thing out of some people's mouths is, what did you do? Because if we want to believe that fertility so we can fix that, we want to believe that we've got control over miscarriage, right? We want to believe if we just do everything right, there's a 0% chance that we're going to have a miscarriage. And that's not true. And we need to do better. It's not birth control. It's not funerals. It's not having a previous marriage. It's none of that causes a miscarriage. It's chromosomal anomalies causes miscarriages. But I talked a little bit about the grief that comes when you believe it's your fault. And that's what we see in the research. We see nearly half of women, and I think this is actually an underestimate in his study. He and I have talked a little bit about how he did the assessment. I think that the majority of women, well over the majority, feel at least some portion of guilt because they've all been led to believe that if a woman has a miscarriage, it's her fault, right? But then women feel like it's their fault and they don't want to talk to anybody about it because what if somebody else confirms it's my fault, and so then I'll just suffer in silence. And it's a really awful emotional experience for women and for their partners. And partners honestly just get ignored when it comes to reproductive losses because everybody is focusing on the person who had the reproductive loss. But partners grieve too. I have female and male partners coming into the clinic after their partners had a loss and saying, there just wasn't anybody that I could grieve with because then I felt like I was a jerk because I was taking attention away from her. This desire to blame women, and I could go into a historical, feminist rant of how all this started, but I won't. But I'll shorten it and say that it really just comes back to this idea of wanting to believe in fairness and fairness when it comes to reproduction. And if we don't have control over who has a miscarriage, then it means this unfairness might happen to me too. It means that I could potentially have a miscarriage. But most of us want to believe that miscarriages can't happen to good people. Bad things only happen to bad people, right? And it kind of shatters our belief in our ability to keep ourselves safe from any kind of harm that might exist. And it's really hard, and it's a lifelong struggle for all of us to learn to accept the limits of our control. But we have to learn to accept that, because if we don't, if we continue to blame ourselves, again, it makes our bereavement that much harder. So this is just a summary of everything that we've talked about, that even though lots of people believe that stress can affect infertility and miscarriage, and believe that that can happen because of this cascading effect of the stress hormones on the HPG axis, it's not true. It's not true, and we need to help patients be able to understand that. This is my oversimplified summary. If you forget all the research that we talked about, number one thing is never, never, never tell a patient to just relax. Not only is it not helpful, but it is not true, and it actually harms women and harms men. And so instead, what I say to them is, of course, stress matters and distress matters, and we want to help you work to feel better, but even miserable women get pregnant too. So let's just work on seeing if we can help you be happier and cope better. So we know then that stress is not a cause of infertility or miscarriage, but you know what it is? It's a consequence of infertility and of reproductive loss. And stress is caused by all sorts of aspects of treatment. There's aspects related to decision making. So first, there's the costs that we talked about. For cancer patients, they're already experiencing their oncology bills, and now they're going to have fertility bills on top of it, although we make it really cheap for cancer patients to go through this. And yes, I can share the slides with you. I'm trying to watch as people are talking in the chat box. Again, just the cost of fertility treatment. Again, if you're not in a fertility mandated state, you're going to be paying out of pocket. There's certainly religious and ethical concerns when we talk about making embryos in IVF, and they wind up with extra embryos at the end of treatment. Do they feel okay with thawing and discarding those embryos? Do they feel okay with having them donated to research, or do they want to donate them to another family? How do people feel about genetic testing of embryos? What if we find out an embryo has trisomy 21 Down syndrome? What do we do with that embryo? What are the conflicts that somebody has? We're going to know the sex of embryos when we do genetic testing. How do people feel about sex selection? We know that people get more emotionally attached to an embryo when they know the sex of an embryo. We also have to think about posthumous reproduction, whether it's one of our cancer patients who dies after they've frozen sperm or eggs or embryos, or our infertile couples and one partner dies. Do they keep using the sperm and eggs and embryos to have families? And how does everybody feel about that? Lots of people have concerns about third-party reproduction. Again, donor sperm, donor egg, donor embryo. You know, anonymity is a thing of the past. We don't call it anonymous donation anymore. It's agency donation. Because of 23andMe and Ancestry.com, your kids 100% will find out to whom they're genetically related and to what degree. And so not only for that reason should you tell your kids how you conceived them, but also because what we know from the research is that when we lie to kids about how they were born and they find out on their own, and they will find out on their own, then they're going to feel betrayed and hurt and wonder if you're embarrassed about the way that you had them, or if there's something wrong or a shameful process that you went through to have them. And it is in children's best interest to tell them how they were born. But there's also, again, all those costs and other issues associated with third-party reproduction. In the U.S., you have to be under 55 in order for a fertility clinic to get you pregnant, despite what you've probably seen in other countries. The oldest woman in the world to get pregnant and have a baby. Now the oldest woman was 76. In India, she used donor sperm and donor egg. Her husband was 80. The day she delivered, she went into the ICU, and her husband also had a heart attack that day. And they're already in a country with a lower lifespan, and their child will not have a parent survive to adulthood for them, which is in part why we have age limits in the U.S. And this is just talking about some of the additional cost data with third-party reproduction and some of the ethical concerns that get raised with how old is too old. The woman in this picture, actually, she looks a lot older than she is. I'm sorry to say that, but oops, my laptop fell a bit. She's actually only 52. She just looks a little bit older than her stated age. But Sperm donation isn't cheap, right? For our same-sex couples or our single women going through fertility treatment, about $1,000 for a vial of sperm now, about $1,000 for the procedure and other costs associated with it. And oftentimes insurance discriminates against single women and same-sex women. Egg donation, typically the fees for the donor and the agency combined are about $17,000 plus about $25,000 for a cycle of IVF if you don't have insurance coverage. And I should have updated the oldest woman to get pregnant with donor egg is now 76. Embryo donation, we don't call it embryo adoption. There are a lot of reasons why we don't call it adoption. The biggest reason is that embryos are not human beings. Some people may believe that. We do not. If an embryo is a human being, if an embryo is identified and is given personhood, then IVF goes away, right? Because then we're making babies, literally making babies in Petri dishes. And when anybody has excess embryos that they're not going to use, then that's murder, right? Because we thought and discarded a baby, right? So we don't call it embryo adoption. Embryo donation costs about $10,000 is what I'm going to say the average is. It can be a little higher. For agencies who do treat embryo donation as adoption, they also add a home study in, just as they do in adoption, and that gets added to the cost. And then again, gestational surrogacy, $150,000 to $200,000. So lots of folks are not able to afford to do that. So that's just even getting into treatment. There's all sorts of psychological stressors that are caused by fertility treatment. But then once you get into treatment, there's also all sorts of stressors. There's the side effects of the medication that you're going to take. And they typically do not make you crazy. I know I put this joke in there, but the hormone that does tend to make women feel the worst is a pill that we use in artificial insemination. It makes women feel like they're going through menopause. So hot flashes, tearfulness, fatigue, all that sort of stuff. The IVF meds typically cause whatever the woman's normal PMS symptoms are for a couple of days in the cycle. So the IVF medications, surprisingly, are far more tolerable than the medications for artificial insemination. But there's other aspects of treatment that are stressful. Nobody loves needles. And if you do IVF, it's 2 to 3 shots a day, self-administered shots a day for a week and a half. And then when you get pregnant, if you've done a particular type of IVF, you have to do an intramuscular injection in your butt. So basically a flu shot in your butt once a day for the first 2 months of a pregnancy. And for people who hate needles, it's unpleasant, right? Even for people who don't hate needles, it's unpleasant. There are also a lot of vaginal exams, and think about women who've been sexually assaulted and the emotional experience that can come there. Think about our transgender patients, right? Our transgender male patients who are coming in to freeze their eggs before they either start puberty blockers or have their ovaries removed. They're going to have to be exposed to these vaginal exams, and that's difficult. For our trans women to masturbate, right, to get sperm is also difficult emotionally. There's a lot of people who get nervous about sedation because we have to sedate people to do the egg retrieval. It's twilight sedation, like similar to when you have a colonoscopy or your wisdom teeth removed, but there's still a lot of people who get nervous with that. There are other stressors associated with relationships. It's not an easy process to go through this. If you've been trying for at least a year before you even get into a fertility clinic, and then you're in fertility clinic for as long as 8 months or longer, that's going to create the possibility of some conflict, particularly for couples who haven't developed good communication skills. We see a lot of sex dysfunction, particularly for the men. When men are told they have to perform today and right now, and they know that if they can't, that their wives are going to be mad at them, that's a lot of pressure. And if you have a difficult time ejaculating once, then that gets stuck in your brain, and the next time you're supposed to have sex at this particular time, which loses all of its enjoyment, right? Then it's that much harder to have another erection or ejaculation. There's all sorts of work stress that pops up because you got to come into the clinic a lot. When you do IVF, you're in the clinic almost every other day for blood draws and vaginal ultrasounds. And you got to think about, am I going to tell my boss or am I going to try and hide this from them, and how do I do that? There's the stress that comes from having losses, from having undergone multiple treatment cycles and not getting pregnant. And what we see from the research is, although it's fairly diverse, as many as 50% of the women, slightly less than that for the men, but as many as 50% of the women can develop clinically significant symptoms of depression. Again, about half women, slightly less for the men, can develop clinically significant symptoms of anxiety. And again, this just gets worse and worse throughout the process and can become particularly bad. But I also want to talk a little more uniquely about the grief that patients experience when they're going through fertility treatment, grief that they're not able to get pregnant on their own, or grief that they've had a loss, but particularly about the way that grief is experienced for partners and for same-sex couples or transgender people or couples. When a person or a group of people is not expected to either be able to have feelings, like men, right? We see them, they're supposed to be sturdy oaks in the rock, and they're not supposed to be the ones that are upset, they're the ones that are supposed to comfort us. Or a same-sex couple who their friends or family doesn't respect their relationship, or a society that has historically and continues today to not respect their relationships or their ability to be parents. We have no federal law for parenthood. That means that outside of the state of Illinois, where we have really amazing reproductive laws, same-sex couples have to adopt their child with the other partner because they may not be genetically related to them. Or for our transgender people or couples and their identity is not valued or validated, the grief that those individuals experience is not able to be shared as much with other people. And we call this disenfranchised grief when somebody doesn't even recognize that you deserve to grieve because you don't deserve to have your relationship or to be a parent in the first place. And doctors sometimes do it too. And there can be discrimination that occurs in clinics that they either don't work with same-sex couples, which still today happens, or they invalidate the partners or the couple's experience and they're sort of flippant with them if they experience a loss. But the grief is real for everyone, and we need to acknowledge that. It's not just the person who's experiencing the miscarriage, it's everyone around them that might be having a hard time too. And they deserve our support. For our cancer patients, it's also hard for them because they have cancer. And they're worried about if they're going to die, lose their hair, lose their breasts, lose their testicles. What's their future going to look like? Is anybody ever going to love me because I have cancer? Is anybody ever going to want to have kids with me because I have cancer? Right? There's also worry for them about this delay in starting fertility treatment to spend the time to go through, or to delay cancer treatment to go through fertility treatment, even though it's only 2 weeks to do a cycle of IVF. Obviously, sperm banking is much faster, but to do a cycle of IVF or egg retrieval, even a 2-week delay in someone's cancer feels like too long sometimes. And for women who are going through this process, they know that they're going to have a higher chance of having a baby in the future if they have sperm to fertilize their eggs. Embryo technology is just better than egg freezing technology. So do I pick a sperm donor? Is anybody ever going to want to have kids with me with those embryos, right, going forward? And there's a lot of thought then that goes into, do I take the risk and just freeze eggs? Do I make embryos? Do I just start treatment and cross my fingers that I still have some eggs left at the end of cancer treatment? And then there's a lot of concern, again, about posthumous reproduction with our cancer patients. Those are the patients that we have lost along the way. And talking to them and their families about what they would want to do with sperm or eggs should they pass away as the result of their disease or some other reason. And then they're also worried about this possibility of future fertility. If I don't freeze my eggs or sperm or embryos, maybe I can't afford it. Maybe my cancer is so severe that there's no time. And we always work with the oncologist, and we do say no to some patients that it's too risky to freeze their genetic material. They've got to start treatment. But if I go through cancer treatment, whether I freeze eggs or sperm or not, what if it doesn't work? And what if I can't become a parent? What am I going to do? And can I really afford egg donation, sperm donation, or a gestational carrier in the future if I'm not able to carry moving forward? For single women, it's also emotionally difficult. I think people think, oh, it's just freezing your eggs. There's all these women now who are just, coming in, freezing their eggs. Their companies are paying for it. So first of all, most companies don't pay for it. Some do. But the women who come in to freeze their eggs, so in our clinic, every patient who undergoes IVF, third-party reproduction, egg freezing, regardless of the reason you're doing any of those things, you see one of the 3 psychologists before you get started. 100% of the time, the women who come in to freeze their eggs, we start having their pre-treatment consult and they start crying. None of them want to be here. They've all imagined themselves in a very different place in their lives, with a partner, already a mom, and it hasn't happened for them. And they're devastated. Most of them are already in therapy. If not, I find a lot of them therapists. They are distressed about even needing to think about banking their eggs. And they also understand that it may not work. It is not an insurance policy. It's bothersome that people use that phrase. Insurance policies kick in and work and help us when we need them. That's not how egg freezing works. We freeze the eggs and then you come back and we see if they work. We don't know if they're going to work, but we'll freeze some and then we'll see, right? So there's a lot of decision making that goes into and cost that goes into freezing our eggs. For same-sex and transgender couples, even more decision making, even more money, right? Because even with our transgender patients, often we're missing one of the pieces we need, whether it's sperm or eggs or uterus. Or even if we have a uterus, the person who has the uterus doesn't feel comfortable using their uterus to carry a child. So there's all those costs of third-party reproduction. There's worry about how they're going to be treated in the clinic. There's a study from 2015 that looked at something like 20,000 transgender people in the U.S. and found that I think it was 2% of them had actually been physically assaulted by a healthcare provider in the U.S. So patients are going to be afraid of how they're going to be treated, and they're going to be unsure if they can even afford to move through treatment at all. I would also argue that part of the problem for our our same-sex and transgender patients is not just the fear of how they're going to be treated in the clinic, but how they're going to be treated outside of the clinic if this does work for them. If they do get pregnant and do have babies, what does that mean for them in their social support groups, from their families, their friends? There's unfortunately some really inappropriate stereotypes of same-sex individuals and transgender parents or people as incompetent parents. We actually have quite a bit of research. Kids of transgender parents, kids with parents who are gay, absolutely just as awesome as kids with cishet parents, right? No differences academically, socially, emotionally, and so on. So it's not true. But what we do know is that even though there's all this stigma, both in fertility clinics and in society in general, is that most same-sex individuals and transgender individuals do want kids. And transgender individuals in particular are important because most of the time nobody talks to us about transgender people, and lots of us have never even met somebody who identifies as transgender. So we see lots of patients in our clinic who who are transgender, and we see them to freeze sperm, to freeze eggs, to freeze embryos, and the research that we have shows that the numbers are even getting higher in terms of more and more trans women and trans men reporting a desire to be able to be genetic parents in the future. For our same-sex couples, there's also decision-making and costs because they are either transgender or in a same-sex relationship related to family building. I mentioned before that although we have federal marriage, we do not have federal parenting. I think people mistakenly believe that because we have federal marriage, both parents' names go on the birth certificate. That's not how that works. It is how it works in Illinois, but not in other states, and that takes a lot of time and energy and effort. And I recently had some same-sex couples who really started to get stressed out about the most recent Supreme Court nominee, and all of them hurried up and got on with attorneys to try and finish whatever processes they needed to complete to finalize adoption. But overall, regardless then of why you're coming into fertility treatment, it's stressful to come in for fertility treatment. And because it's stressful, I believe that every single patient who comes into a fertility clinic should receive psychological counseling to address mood, coping, communication skills, etc. And in summary, I know that was a lot. I know it was fast. I was trying to leave some time for questions at the end because we usually have lots of questions with this talk. It is not an easy task for most people to conceive, right? It's anxiety provoking at a minimum, and sometimes it can require some fertility treatment. But that anxiety that somebody experiences related to trying to build their family is not the cause of their infertility. Stress does not cause infertility. It does not cause miscarriage. We do a really bad job as a society in talking to people about how all of this works. And I believe that we can do better. And one of the ways we can do better is certainly from medical teams. And I think medical teams benefit from having mental health professionals in the clinic. Again, there's 3 of us sitting in our clinic. But we need better communication, better education among patients, families, society, and more broadly. We need to work to talk about how all of this makes us feel rather than suffer in silence. Because our inability to share our feelings with others, or our avoidance of sharing our feelings with others, only does us harm, and it does harm to both women and their partners, or men and their partners. And so overall, what I would say is all of us need to be educated about the psychological distress associated with infertility, and to do better in how we counsel patients who are coping with infertility and loss. And that's all. Thank you. And I'll take any questions anybody has.
I can start off. I first wanted to thank you for such an insightful presentation, and also for debunking a lot of misconceptions that we have surrounding fertility and infertility. I mean, I learned a lot. And I'm just wondering, since this is such a specialized field, what were some of the training experiences that you had along the way that were most helpful for preparing you for this, or leading you in this direction of reproductive psychology?
So I'm going to say none, and then I'll explain what that means. So this is not where I thought I was going to wind up. So I am at my core a trauma psychologist, and my research in grad school was on sexual harassment and sexual assault. And I fully planned, best laid plans, I fully planned on winding up in a trauma clinic somewhere. And when I graduated, it was 2008, and the economy had gone, right? And there weren't any jobs, like no jobs. So my initial plan was I was going to stay on. I did my year of residency and postdoc fellowship at Rush, and I was going to stay on at Rush in their outpatient psychology clinic, and wait to see if I could find a trauma clinic of some kind to get into. But I also was emailing around, and what I thought was, well, I tend to work with female trauma patients, and I'll talk about celebrities too. I just saw that pop up. But I tend to see female patients who are associated with trauma. And I thought, well, where could I see the most female patients? OBGYN. So I emailed various academic departments of OBGYN, and I emailed the medical chief at Northwestern and said, here's who I am, and here's why you should want me, right? And I had heard that they were thinking about having a psychologist in their HIV OBGYN clinic, which I was like, oh, that sounds right up my alley. And he said, no, they were thinking about it, but they weren't ready to do it. And he said, but REI, which is reproductive endocrinology and infertility, has psychologists in their clinic. Would you mind if I forwarded your materials over to them? I said, sure. And then I Googled REI. I'm like, what is that? And they called me the next day. And they said, well, we actually did have an opening. We've finished all of our interviewing process. And we had closed the APA notice like months before, something like that, which is why I hadn't seen it. And can you come in this week? And I was like, okay, fine. So I went in and I met everybody, and they were hilarious, right? They were awesome. We had drinks at lunch, right? They were cool people, right? And I said to myself, I think I'm going to get offered this job. And I got offered the job, and I said, I don't really want to do this, because it's like bunnies and rainbows and getting people pregnant. What's that crap? Right? And I didn't realize it's trauma psychology. Right? And I didn't realize how much social justice was involved in fertility, in working with our transgender patients, our single women, our single men are same-sex couples. And it is actually the perfect place for a feminist to be. And so actually all of my training, none of it was reproductive. I actually learned on the job all of the reproductive information, but all of my training prepared me to work with the trauma of reproduction. Does that answer your question?
It does. And so that makes a lot of sense, where you can learn the specifics of reproductive medicine, but it's your culmination of all of your training that prepared you to be there.
That's exactly right.
Thank you. Looks like we have another one.
Yeah, was that the celebrity question?
Yeah, it looks like it. So what role do you think celebrities have in increasing awareness about miscarriage and infertility? Just thinking about Meghan Markle's recent statement.
Mm-hmm. So I think with miscarriage in particular, not with infertility, but with miscarriage in particular, celebrities are really, really being helpful. From Mark Zuckerberg being a man talking about miscarriage to Hillary Baldwin, if I'm saying her first name right, to Meghan Markle, all of the people who are now, also, why am I blanking out, Chrissy Teigen, all of the folks who are talking about having miscarriages and unfortunately, but appropriately normalizing the experience, helping women and men feel they're not alone, I think is amazing. I do think Chrissy Teigen has done a good job for infertility in general and the need for IVF, but what I would argue in general with celebrities is they're part of the problem when it comes to thinking about women being able to have a pregnancy at any age. And it's easy because we have, Janet Jackson, who's 50, who had a baby, who very clearly used donor eggs. You cannot get pregnant with your own eggs at age 50. It's impossible, right? And people would say, well, maybe she froze her eggs. And I say, yeah, we didn't have good egg freezing until 2014, and she was already 47 or something, right? Same thing, we have, who's the beautiful woman from, I was going to say from James Bond, but they're all beautiful. Halle Berry was 47 or 48 in all likelihood used donor eggs, and it's totally fine, right? And then the really tall blonde lady who was in the Rambo movies was 55 and just had a baby. Anyway, there's a lot of women who are older celebrities who are getting pregnant and talking about sometimes using fertility treatment and sometimes not, but never acknowledging that they've used donor eggs. And I get it. It's private. You don't have to share with anyone. And I get what the paparazzi would do and the awful things they would say, oh, so it's not your baby. You use donor eggs, it's not your baby, right? Or what they might say to kids. But it does send a false message to women that, see, I can have a baby at any age I want. And then I saw another question. I actually can't see the questions. I don't know why.
I can read it for you, but
okay.
Thanks for answering that one. So they're both, contributing and also part of the problem. They're helping and hurting. For those of us working in primary care settings, what are some of the ways that we can open up conversations with our patients about whether infertility or miscarriage is something that they're struggling with?
Well, I think what we can do, especially when we're doing our initial intakes with a patient, is what we talk to them about what their current relationship or family status is. We can also say, and what are your hopes for the future? Do you want to have kids? If you're single, do you have plans to move forward with motherhood, or are you waiting to have a partner? What are your thoughts? And let them open the door to talk about what their hopes and dreams are. There's plenty of women who want to be single moms. There's plenty of men who want to be single dads. It's a perfectly lovely choice. I say that, and I'm child-free, and I work in a fertility clinic, which is also interesting. But for the folks who say, I've always wanted to be a mom, or I've always wanted to be a dad, and they don't have a partner, they're automatically probably going to identify the distress that's associated with that, and then that gives you a lot to work with.
The next question is, what are your suggestions for addressing how medical providers speak with their patients about infertility or pregnancy?
It really starts with OBGYNs, I think. So I don't want to ignore the men, but men make new sperm every time their heart beats, right? And while men can certainly experience infertility, men don't have the same annual doctor's appointments that we do, although I think they should. And if they did, then I would encourage their doctors to talk to them about that. for men, it's more men have to bring it up because they just don't have doctor's appointments. But for us, we need some honesty from our OBGYNs. My OBGYN, who knew I worked in a fertility clinic when I started working at Northwestern, never once brought up whether or not I wanted to be a mom. Now, I didn't, but she never asked me. And so at one of my annual appointments, I said to her, you know, you've never asked me if I want to have kids. And I think I was 41 at that point, right? Which I wasn't probably going to be getting pregnant with my own eggs, even if I wanted to. There is a chance, but it's in the low single digits at 41. And she said, oh, do you want to have kids? And I said, no, I don't. But I realized that you never asked me and that we hadn't talked about it. And I said, you know, I work in the fertility clinic. She's like, oh yeah, I know. And I said, I think it's something important that we should talk about, and then you can document that you asked me and that I said that I don't want kids. I shouldn't have had to do that. And she knew that I worked in the fertility clinic, and she didn't ask me if I wanted to have kids. Unfortunately, I think it's going to be on us as women to bring it up at our annual appointments to say, hey, you know, I think I want to have kids at some point. I'm XYZ years old, and I'm XYZ in terms of partnership status. Can we talk about that? And I think we need to do a better job within the field. And it's why I talk about this at every conference I go to. And I call OBGYNs out. And I have many friends who are OBGYNs. They don't hate me, I don't think. But I talk to them about how we've got to talk honestly about age and chance of success. And we've got to talk about 35 versus 38. And we've got to talk about it, because then women say, oh, people are just trying to fear-monger you about 35. And then they don't make decisions that they might otherwise make if they knew that part of the reason that we talk about 35 is because 38 is coming, and that we really want women to be able, and men to be able to have as many children as they want to be able to have. But it's largely going to be on us to bring it up, just like it's on us to bring up sex dysfunction. Docs never ask us about sex dysfunction either.
Thank you. And it looks like we have one more question here. So this is about the subsidized egg freezing. So there's some concern that this is more to benefit the company and that people with uteri could feel pressured to take the company up on it. Any thoughts about this or insights from your clinical experience?
Yes, and I've also published a manuscript on it. So we did a research study where we looked at medical students and law students and surveyed them about exactly this and how they would feel if their employers covered egg freezing, because they actually do at Northwestern. So I said that largely egg freezing isn't covered, but at some places it is. In tech fields, technology companies will cover it. Medical programs, at least ours, will cover it. And sometimes law firms will. Now, do I think the law firms are offering it because or the med schools are offering it because it benefits them? Oh, yeah. Yeah, it definitely benefits them to have women delay their family building. But it also benefits them because it attracts women to those jobs, because it's a benefit that can be offered to them. And that even if women were at a company that didn't pay for it, they're still going to come in and freeze their eggs. So I think it's not, from the research that I've done and the patients that I've talked to, it is not coercing women into doing it. They would do it anyway, but they're more likely to be able to do it because it's paid for if somebody else covers it. So it hasn't turned out to be, at least from what we've seen, it doesn't turn out to be a coercive thing. Women are actually just using it to their advantage.
Thanks. And I'm just going to check here if we have any last questions. If anybody hasn't had their question answered, can you please just type it in the chat box really quickly? I think that might be it. Okay, well, thank you so much, Dr. Lawson, for a fantastic presentation. And the recording will be posted through the Society for Health Psychology on YouTube in just a few days.
Wonderful.
Thank you.
Thank you guys so much for having me.
You.
Nice to meet you guys.